Module 7, The Child with a Respiratory Disorder. Problems are going to, in the growth and development of the respiratory system, occur more often and with greater severity in infants and children because they have immature body defenses and small, underdeveloped or undeveloped anatomic structures. Their respiratory tract is going to continue to grow and change until they hit about age 12. And during that first 5 years, the airway increases in length, but not diameter. So infants and younger children have larger tongues in proportions to their mouth, shorter necks, narrower airways and structures that are closer together, which leads to the possibility of respiratory obstruction if they have edema, swelling, or increased mucus in the airways. And their ability to breathe through the mouth is not a natural thing. It's not automatic, but it's something that they learn as they go on. Most infants are going to be mouth breathers, so if their nose is congested, it can actually cause some respiratory issues. Tonsillar tissue is enlarged in the early school-age child. The pharynx is still small, but older than 2 years, the right bronchus is shorter, wider, and more vertical than the left. Infants use the diaphragm and the abdominal muscles to breathe, but about age 2, they start using those thoracic muscles, and that change will be completed by about age 7. So let's talk about tonsillitis and adenoiditis. There is a ring of lymphoid tissue that encircles the pharynx, and this is where the adenoids and the tonsils are located, back of the throat. Between the ages of 2 and 10, that lymphoid tissue will normally enlarge, and then it begins to shrink in pre-adolescence. If it becomes the site of acute or chronic infection, it can become hypertrophied and then begin to interfere with breathing and swallowing. It can also cause partial deafness, and it can be a source of infection. These kids will have temps of 101 or higher. Their throats will be sore. They'll have dysphagia. Again, those tonsils can become hypertrophied. They have halitosis or bad breath, erythema, exudate, and all of this can vary depending on the causative organism. A throat culture will often be performed to help diagnose tonsillitis and the causative organism, which is frequently a bacterial cause. This is going to require analgesics, antipyretics, and antibiotics if it is bacterial. Making sure that we reinforce that soft or liquid diet might be easier for the child to swallow, and encourage good fluid intake. It is possible that a tonsillectomy and adenoidectomy might be needed, but it's not the first line of treatment. What is one of the major nursing interventions with a child who's had a tonsillectomy? Is this family teaching, preventing preoperative aspiration, preventing excessive fluid intake, or family interactions? Family teaching. Croup syndromes. This is a group of diseases that typically involve a barking cough, hoarseness, and inspiratory stridor. The disorders will be named for the structures that are involved, and this includes spasmodic laryngitis, acute laryngotracheobronchitis, and epiglottitis. So spasmodic laryngitis will occur between the ages of 6 months to 3 years. It has an undetermined cause, but it may be caused by infection or allergy. Clinical manifestations and diagnoses. This is preceded by coryza, hoarseness, or no apparent signs of respiratory irregularity during the evening. But after a few hours of sleep, the child wakes up with a bark-like cough, an increasing respiratory difficulty, stridor. They become anxious and restless, markedly hoarse, have that low-grade fever, and infection might be present. The episode will usually subside in a few hours, and it frequently will occur 2 or 3 nights in succession. Treatment requires humidifying the air. Exposure to cold air can actually improve symptoms. We need to explain which symptoms can be treated at home and which require emergent medical care, which would be the continuous stridor, the use of accessory muscles, the labored breathing and lower rib retractions, restlessness, pallor, rapid respirations, and making sure that the family are aware that recurrence can occur. With the acute laryngotracheobronchitis, this can progress rapidly and become a very serious problem quickly. The toddler is the most frequently affected population. Usually this has a viral cause, but bacterial with the staph may follow, causing a secondary infection. It generally will occur after upper respiratory infections with fairly mild rhinitis and pharyngitis. Clinical manifestations and diagnosis are made through the hoarseness, barking cough, with that fever up to 102.2 that can progress to marked laryngeal edema, inspiratory stridor, dyspnea, rapid pulse, cyanosis, and acute respiratory distress. We need to maintain that airway and adequate air exchange. Administer corticosteroids. Make sure the air is humidified. Use oxygen. We can do racemic or nebulized epinephrine. Endotracheal intubation may be required if the baby or if the child is in severe distress, and definitely some antibiotics. Close and careful observation will be required. With epiglottitis, this is an acute inflammation of the epiglottis that results in blockage of the airway, usually caused by a bacterial infection. So we see a sudden onset of severe sore throat, dysphagia, high temp of 102.2 to 104, drooling. The child is very anxious and restless and prefers that tripod position to breathe. Requires immediate attention. This can be life-threatening. We need to keep the child as calm as possible, avoid upsetting or causing crying, provide humidified oxygen. Again, endotracheal intubation or a tracheostomy may be necessary. And we monitor with pulse oximetry and administer antibiotics. The acute bronchiolitis and respiratory syncytial virus infection. The acute bronchiolitis is the most common during the first 6 months, and it is caused by viral infection, in most cases the RSV virus, although other viruses can be the cause. The bronchi and bronchioles become plugged with a thick, viscid mucus, and air is now trapped in the lungs. The child is able to breathe in, but they have difficulty breathing out, which hinders the exchange of gases and results in cyanosis. So we see an abrupt onset of dyspnea, sometimes preceded by cough or nasal drainage, a persistent cough, respiratory distress, and increased respiratory rate, nasal flaring and air hunger, marked cyanosis, suprasternal and subcostal retractions. That barrel-shaped chest may appear if this is chronic. Tachypnea at a rate of 60 to 80 breaths per minute. It is diagnosed through our clinical findings, but can be confirmed with lab testing of the mucus from the respiratory tract. It requires supportive care in the hospital, nasal suctioning, rest, increased fluids, humidified oxygen, and monitoring of oxygen. Antibiotics are not given if it is a viral infection because it's not going to do any good. IV fluids, contact and droplet transmission precautions are necessary. Antiviral drugs such as inhalants, the ribavirin, may be given, but it's only given in very specific cases such as the immunocompromised client because it can be more hazardous to give than not. So true or false? A primary tool to prioritize with the child that is experiencing respiratory illness is the blood pressure cuff. This is false. Asthma. This is the spasm of those bronchial tubes caused by hypersensitivity of the airways. Contact with the trigger, which leads to inflammation in the airways. Bronchi and bronchioles will begin to narrow. Edema might be present in the mucous membranes, and we have increased production of thick mucus that actually continues to narrow the airway and can cause respiratory obstruction. Asthma is also referred to as the reactive airway disease. The asthma attacks are often triggered once again by a hypersensitive response to allergens, which might be chocolate, milk, eggs, nuts, grains, food additives, but can also be triggered by exercise or exposure to cold weather, irritants, infections, emotional stress, anxiety, and some may have no evidence of immunologic causes. It can be intermittent with no periods of symptoms or episodes. Chronic asthma will affect the way the child is able to live their life. These clinical manifestations, we can have usually a slow onset, but it can occur suddenly. We have that dry, hacking cough, wheezing, and dyspnea, and the attack will usually occur at night and can cause the child to wake up. And then the child is preoccupied with efforts to breathe. These attacks may only last a few hours, or they can actually last several days. We see thick, tenacious mucus that might be coughed up. They may no longer have symptoms after puberty, but that's not a predictable thing. Coughing can be a major asthma symptom. We diagnose by looking at their past history and their physical examination, which is really very important. Are they using those accessory muscles? Do they have dyspnea, labored breathing, wheezing with auscultation, production of mucus? We look at pulmonary function tests and spirometry measurements. Reversal of airway obstruction with bronchodilators is the definitive diagnostic. So we give them medication, and if they improve, they probably have asthma. So very important to provide family education so they're able to quickly recognize symptoms of chest tightness, respiratory retractions, wheezing, shortness of breath, the increased amount of coughing at night and early morning or with activity. Teach them how to use that peak flow meter and maintain that diary, and make every effort to eliminate those allergens. and decrease or control those asthma triggers. Goals include preventing symptoms, maintaining a nearly normal lung function and activity level, preventing recurring exacerbations and hospitalizations, providing best medication treatment with few adverse effects. And there's some tables in your textbook, table 36.1 and 36.2 to provide more or review information. Don't forget we have the quick relief and the long-term control medications when we're treating. Quick relief is going to be like your bronchodilators. Your control medications are going to be your systemic corticosteroids or inhaled corticosteroids, and the leukotriene modifiers and mast cell stabilizers. We can give these medications also through the nebulizers or metered dose inhalers. So the peak flow meter, once again, to remind you, is going to enable early detection of the asthma attack. A drop in that peak expiratory flow rate and their ability to breathe out quickly are going to help us determine how we're going to treat the client. Cystic fibrosis is a gene mutation that results in the dysfunction in all of the exocrine glands. Major glands that are affected include the lungs, the pancreas, the liver, and the intestines. I apologize. Just a moment here. It is a hereditary autosomal recessive trait, and both parents have to be carriers of the gene for the child to be diagnosed with cystic fibrosis. The mutated gene will block chloride movement, so it leads to production of thick mucus and then will obstruct respiratory passages. Newborn screening has led to earlier detection, earlier treatment options, and better lung functions and outcomes. Used to be a child was diagnosed with cystic fibrosis and they were not expected to live until their teen years. Through improved treatments, there are people living into adulthood. And I know a few years ago of a man who received a lung transplant who had cystic fibrosis, and he was in his mid-30s, which years ago was definitely unheard of. So these clients, initially we may see that meconium ileus in 10 to 20% of newborns. They have bile-stained emesis, a distended abdomen, an absence of stool, and if you kiss them, their skin tastes like salt. If it's not detected in the newborn screening, then symptoms will depend on the severity of the disease and the organ that's affected. Persistent cough, tachypnea, wheezing might be the first sign. They have frequent bronchial infections, barrel chest, and clubbing of the fingers. With pancreatic involvement, we have intestinal malabsorption and severe malnutrition, steatorrhea, increased frequency of flatulence, large, bulky, foul-smelling stools, and diabetes. With the lungs, we have that mucus clog the bronchioles, and it provides an ideal medium for bacterial growth that leads to those infections. We see atelectasis and small lung abscesses, bronchiectasis and emphysema, pulmonary fibrosis, and pneumonitis. All of these lead to severe respiratory insufficiency, pneumothorax, and pulmonary hypertension and respiratory failure. Other organs can be involved, and we see tears, saliva, sweat that is abnormally high concentrations of electrolytes that lead to electrolyte imbalances and even infertility. It is diagnosed by family history, newborn screening, and the clinical symptoms. We have that elevated sodium chloride levels in the sweat chloride test, genetic tests, a history of a failure to thrive, chronic or recurrent respiratory infections, and X-ray findings of hyperinflation and bronchial wall thickening. The principal diagnostic test is that sweat chloride test, and it uses pilocarpine iontophoresis method. Treatment, if we have the meconium ileus, will include hyperosmolar enemas or surgery. Treatment will be aimed at correcting pancreatic deficiency, improving pulmonary function, preventing respiratory infections, laxatives, and enemas for bowel obstruction. We also want to improve the quality of life and provide for that long-term survival. Dietary treatment includes administering pancreatic enzymes, that having a diet that is high in carbs and no protein, no restriction on fats, increased calories, and vitamin supplements. Pulmonary treatment, we want to promote respiratory drainage, administer antibacterial drugs, immunizations, physical activity and inhalation therapy might be necessary, bronchodilator drugs, the recombinant human DNA, mucolytics, nebulizers, humidifiers, and chest physiotherapy. Mechanical devices such as the flutter valve device, positive expiratory pressure mask, and high-frequency chest wall oscillation device, or that percussion vest, might also be used to help mobilize secretions. And home care. It's important for family to learn how to perform chest physiotherapy and operate that respiratory equipment, administering IV antibiotics. They need to be aware of dietary requirements and infection precautions and physical activity. And financial requirements. I mean, community and national resources. This is not a treat and it's gone disease. This is lifelong. So in this slide, you see some different positions for chest physiotherapy and some more with the postural drainage. And this is the percussion vest. True or false? In the newborn, meconium ileus is the earliest sign or symptom of cystic fibrosis. Meconium ileus is treated with gently administered hyperosmolar enemas. This is true. Sudden infant death syndrome, or SIDS. This is going to be the sudden death of an apparently healthy infant, younger than 1 year of age, which remains unexplained after investigation, autopsy, examination of the death scene, and review of the child's clinical history. It is the leading cause of death in infants between 30 and 365 days. Various theories do allow for the cause, but no single cause has actually been identified at this point. Contributing factors, usually the child is going to be 2 to 4 months old. It is a greater threat in the low birth weight in preterm infants. and male versus female, minority and socioeconomic groups, mothers that are younger than 20 years of age, mothers who smoked, used drugs or alcohol during pregnancy, infants who are put to sleep on their stomachs, so the prone sleeping, or infants that are sleeping on soft surfaces with blankets, pillows, and stuffed animals, sleeping on their parents' bed, or they become overheated. The American Academy of Pediatrics does recommend that infants sleep in supine position until they're at least 6 months old. And as a result of doing this, and this has been in place for many years, the incidence of SIDS has decreased. So what happens is we have a rapid, silent, and occurs at any time death of the infant with no evidence of struggle. Our infant is frequently in excellent health prior to their death. A closely related symptom is called the apparent life-threatening event, where the infant is found in distress but responds immediately to stimulation. These infants might be put on the home apnea monitor, where the alarm will sound if the infant does not take a breath within a given number of seconds. And the family learns infant CPR, and the infant will stay on that monitor until they're at least a year old. Nursing care, we have to respond immediately and allow that family to express their grief, encouraging them to say goodbye to the infant, refer them to the National SIDS Foundation, the Sudden Infant Death Syndrome Alliance, and Community Health Nurse. There is concern for subsequent infants, so it's necessary to provide necessary care, support, and encouragement. True or false? The greatest priority of the nurse is to help the parents who have lost their newborn to SIDS figure out what went wrong. This is false. Now your post-test.